Let's discuss obsessive compulsive disorder. By definition, OSD presents with increased frontal lobe metabolism, and number two, increased size of caudate nucleus. OCD, or obsessive compulsive disorder, is a disorder where the patient typically experiences either obsession alone or most commonly a combination of obsession and compulsion. Compulsions typically affect the individual level of functioning. Let's differentiate obsession, vice versa compulsions. Obsessions, this is thoughts that which are intrusive, senseless, and distressing to the patient, thus increase anxiety. This includes fear of combination. Compulsions, these are rituals such as counting or checking, which are performed to neutralize obsessive thoughts. These are time-consuming and tend to lower anxiety. Diagnosis: OCD is seen more frequently in young patients. There is an equal incidence in men than women. OCD coexists with Tourette disorder. Let's go to and talk about the treatment of OCD. SSRI are treatment of choice, like fluoxetine, paroxetine, sertraline, citalopram, and fluvoxamine, which are most commonly used in first-line agent. The main behavior therapy used is exposure or response prevention. The clinical tip is if all of the answer choices offer a pharmacotherapy for OCD are TCA, choose clomipramine. Let's discuss so-called hoarding disorder. Individuals with hoarding disease have problems discarding their possessions, leading to persistent accumulation of possessions, such that the home is overwhelmed by clutter. The hoarding affects the individual level of functioning and impairs his or her ability to maintain a self environment. The treatment: number one, SSRI are treatment of choice. Number two, patient benefit from behavior modification technique or psychotherapy, such as cognitive behavior therapy. Let's talk about body dysmorphic disorder. Individuals with body dysmorphic disorder believe that some body parts are abnormal, defective, and misshaped, although others do not see these perceived defects. These beliefs significantly impair in the patient level of functioning. Patients spend more excessive time checking the mirror and seeking reassurance. SSRI combined with the individual psychotherapy of treatment of choice. Let's talk about post-traumatic stress disorder and acute stress disorder. Let's go to the next slide, slide number 32. Diagnosis of PTSD and ASD is the main feature is correctly identifying the diagnosis is determining of the time period. Once again, the main feature is the time period when the traumatic events occur in relationship to the symptoms. Depression and substance abuse must be ruled out because of both worsen the diagnosis. The treatment, the first line of treatment, number one, the first line of treatment is paroxetine and sertraline. Prazosin is used to reduce the incidence of nightmares. Number two, relaxation technique and hypnosis are proven to help for this patient. Number three, psychotherapy after traumatic events will allow to determine the coping technique and the acceptance of the event. Let's discuss so-called generalized anxiety disorder. This is disorder in which patients experience excessive anxiety and worry about most things, lasting more than 6 months. Typically, the anxiety is out of proportion to the event. This is accompanied by fatigue, concentration difficulties, sleep problems, muscle tension, and restlessness. Patients are usually women and complain of feeling anxious as long as they can remember. The treatment is number one, SSRI, such as fluoxetine, paroxetine, sertraline, or citalopram, which are indicated in this disorder. Number two, venlafaxine or buspirone are also effective. Number three, psychotherapy and behavior therapy are beneficial as well, but they are not considered first-line agent for these patients. We have here a clinical event, a clinical vignette in which describes 35 years old woman reports she experienced palpitations, dizziness, increased sweating for at least 8 months. She had visited numerous physicians and none have been helpful. Her husband is concerned because she cannot relax and worry about everything. She worries about her parents' health, even though they are healthy. She worries about her finances, about her husband, assures her that they are financially secure. What is the most likely diagnosis? A, generalized anxiety disorder. B, phobias. C, panic disorder. D, adjustment disorder. E, social anxiety. The right answer here is A. A like apple. The main feature is generalized anxiety disorder, which is a chronic worry about things that are not have no merit of concern. It is also accompanied by other symptoms of anxiety, as well as sleep and concentration problems. Here we have a nice table of anxiety medications and their side effects. On the left side is the medications, and on the right side is the side effects. Benzodiazepines such as diazepam or lorazepam, clonazepam, alprazolam, oxazepam, chlordiazoxide, temazepam, and flurazepam. All of them have side effects of sedation, confusion, memory deficit, respiratory depression, and increase addiction potential. Let's go to the next slide. Slide number 34. Buspirone has just few side effects such as headache, nausea, and dizziness. Lorazepam. So the next table is the list of anxiety medication and their specific side effects. Lorazepam is usually frequently used in emergency situation because of it can be given intramuscularly. Clonazepam, it may be used if addiction is a concern given it is long half-life. Chlordioxine, oxazepam, or lorazepam, this is usually used frequently in treatment of alcohol withdrawal. Lorazepam and oxazepam are drugs of choice in patients with liver disease problems. Alprazolam, this is usually frequently used in panic attacks and panic disorder. Lorazepam, temazepam, and triazolam, this is approved as a hypnotics, rarely used. And we have to know that fumazanil can cause seizures in benzodiazepine-dependent patients. It causes acute withdrawal, which can be tremor or seizure similar to delirium tremens or alcohol withdrawal. And we need to remember also that fumazanil is a benzodiazepine antagonist used only when let's discuss substance abuse disorder by definition of specific substance-related disorder and how it presents. On the left side, it's a substance use disorder. On the right side is definition of the disease. Intoxication. Number one, intoxication, which is a reversible experience with a substance that leads to either psychological or physiological changes. Withdrawal, cessation or reduction of the substance leading to either psychological or physiological changes. Use, substance use, maladaptive pattern of use of substances that leads to engaging in hazardous situation, legal problems, inability to fulfill obligation, and continues despite adverse consequences and craving. Prevention and treatment of intoxication and withdrawal. Alcohol, usually patients are talkative, moody, gregarious, sullen, disinhibited. The treatment of intoxication is mechanical ventilation if severe intoxication with alcohol. Signs and symptoms of withdrawal tremors includes tremors, hallucinations, seizures, and delirium tremens. Let's go to slide number 36. Amphetamines and cocaine, which is synthetic form bath salts, presents with euphoria, hypervigilance, autonomic hyperactivity, weight loss, papillary dilations, and perceptual disturbances. Treatment of intoxications is with antipsychotics and or benzodiazepine and or antihypertensives. Signs and symptoms of withdrawal includes anxiety, and signs and symptoms of withdrawal include anxiety, tremulousness, headaches, increased appetite, depression, risk of suicide. For substance use of cannabis, synthetic form known as K2 or spice. We have improved motor coordination, impaired motor coordination, slow sense of time, social withdrawal, increased appetite, conjunctival injection. So in cannabis, we have impaired motor coordination, slow sense of time, social withdrawal, increased appetite, and conjunctival injections. For treatment of intoxication, we need to consider use of antipsychotics if patient is psychotic. Signs and symptoms of withdrawal includes irritability, anger, anxiety, sleep problems, restlessness, and appetite problems. For substance abuse for hallucinogens, we have signs and symptoms of intoxication, which includes ideas of reference, perceptual disturbance, possibly increase in so we have idea of reference, perceptual disturbances, possible increased psychosis, impaired judgment, tremors, incoordination, and dissociative symptoms. The treatment of intoxication includes antipsychotics and or benzodiazepines and or so we have antipsychotic treatment is with antipsychotic and or benzodiazepine and or talking down. Signs and symptoms of withdrawal, none. If we have inhalations, we have for substance abuse of inhalants, we have apathy, aggression, empire, judgment, stupor, or coma. We treat this with antipsychotics, and signs symptoms are withdrawal is none. Let's go to the next slide. Let's continue. If we suspect someone is an alcoholic, we need to do a CAGE test, CAGE test. 2 positive responses to the 4 questions are considered positive and indicate further assessment. So C, it means that have you been ever tried to cut down on your drinking? A means have you ever got annoyed by others who have criticized your drinking? G, have you ever felt guilty about your drinking? And this is slide number 38. E, have you been used alcohol as a eye opener? The treatment is the most commonly abused and most commonly tested drug is alcohol. If you have the treatment is number 1, detoxification, usually 5 to 10 days, mostly in hospital setting to ensure safe detoxification. Number 2, rehabilitation, usually 28 days or more, within focus of relapse prevention technique. Number 3, Alcoholic Anonymous, most effective. Number 4, Narcotics Anonymous. Number 5, pharmacological treatment often includes disulfiram, naltrexone, and acamprosat. We have here is a clinical vignette which describes 65 years old engineer which was taken to ER after being involved in MVA. He suffered a fracture of the femur and some cuts and bruises. He is admitted to the medicine floor and started on oxycodone. The day after admission, he appears confused and has observed tremors of both extremities. He becomes concerned about bugs on the wall in his room and asks for your help. Question is, what is the most likely explanation of his symptoms? A, brain contusion. B, alcohol withdrawal. C, oxycodone intoxication. D, brief psychotic disorder. And E, schizophrenia. The right answer is B. And the right answer here is B. Most withdrawal questions are asked in the hospital setting on the next day after admission. The patient presents with uncomplicated alcohol withdrawal characterized by visual hallucination and tremors. Let's go to the next slide, please. Let's continue with somatic symptoms and related disorder, factitious disorder, and malingering. Somatic symptom disorder, by definition, presents in female to male ratio in 20:1. This disorder is characterized by presence of one or more somatic symptoms, which are distressing and cause impairment in functioning. The patient has excessive thoughts, feeling, or behaviors related to the somatic symptoms that are manifested by disproportional and persistent thoughts about the series of the symptoms, intense anxiety about the symptoms, and excessive time developing to the symptoms or health concerns. A patient must be symptomatic for more than 6 months to be diagnosed with somatic symptom disorder. The disorder is seen frequently in young women and usually have some psychological component of which the patient is unaware. Psychotherapy is the treatment of choice given to psychological sources of the symptoms. We have so-called other symptoms. Psychotherapy is a treatment of choice given the psychological source of the symptoms. On the lower part of this slide, slide number 39, we have the type of disease and definition in diagnostic criteria. We have illness, anxiety disorder, which patient believes that they have some specific disease despite constant reassurance. For a conversion disorder, typically conversion, this typically affects voluntary motor or sensory function that are indicative of medical condition but usually caused by psychological factors. Can be associated with so-called labile indifference. Labile indifference, where the patients are unconcerned about his or her impairment. So the patient is unconcerned about his or her environment. We have a clinical scenario with 35 years old married woman with 3 children. She was taken to the doctor's office after daily complaints of dizziness, nausea, and headaches for the last 6 months. The doctor is intensively work and she's intensively bothered by her symptoms to the point that she now stays at home and avoids both going to work and caring about her children. She has been tried on numerous medications, but none has proven to be beneficial. Neurological examination found some abnormalities with Which of the other would be most indicative for this patient? A. Lorazepam. B. Sertraline. C. Individual psychotherapy. D. Lithium. E. Risperidone. And the right answer here is C. The patient has somatic symptoms disorder, which is treated with individual psychotherapy, given the psychological issue has been of the cause of his symptoms. He or she should have one primary caregiver and not to be sent to specialist. Lorazepam, a benzodiazepine, treat anxiety disorder. SSRIs such as sertraline treat fibromyalgia and depression. Lithium help bipolar, and risperidone is for psychosis. Next clinical disease is fastidious disorder. By definition, fastidious disorder, this is fastidious disorder, the individual fakes an illness in order to get attention and emotional support as a patient role. This can be either a psychological or physical illness. Psychological symptoms include hallucination, delusions, depression, and bizarre behavior. Physical symptoms include abnormal pain, fever, nausea, vomiting, or hematomas. At times, one individual may inflict life-threatening injury on themselves in order to get attention. This behavior may be compulsive. At times, when a caregiver fakes signals and symptoms in another person, usually a child, in order to assume a sick role. The diagnosis is fastidious disorder imposed on others. When signs and symptoms are faked on oneself, the diagnosis is fastidious disorder imposed to self. Let's go to the next slide. Fastidious disorders is motivated unconsciously. Malingering is motivated consciously. The diagnosis: typically, patients with this disease are women which may have history of being employed in healthcare. Men have more physical symptoms. The patient's ultimate goal is gain admission to the hospital. You must always exclude any medical disorder with similar symptoms. Fastidious disorder cannot be diagnosed without first confirming that legitimate medical illness is not presented. Treatment: there is no specific therapy which is proven to be effective in these patients. When child is involved in fastidious disorder imposed on others, Child Protective Services should be contacted to ensure the child's safety. Let's go to the next clinical topic, which is malingering. Malingering is characterized by conscious production of symptoms, signs and symptoms for a secondary gain, such as avoiding work, evading criminal prosecution, and achieving financial gain. Malingering is not a mental disorder. Diagnosis and management. Malingering is seen more frequently in prisoners and military personnel. It can be typically diagnosed when there is a discrepancy between the patient's complaints and actual physical and laboratory finding. In medical evaluation reveals malingering, then confront the patient with the outcome. Let's go to the next slide. Slide number 42. We have to remember that a lack of cooperation from patient is characteristic for malingering. Let's go to the next disorder, which is adjustment disorder. Adjustment disorder is characterized by maladaptive reaction to identifiable stressors such as loss of job, divorce, or failure in school. The symptoms usually occur within 3 months of the stressors and must remit within 6 months of removal of the stressor. The symptoms include anxiety, depression, or disturbance of conflict. Have been enough to cause impairment in functioning. Psychotherapy is the treatment of choice. Both individual and group therapy could be used to be effective. Let's go to the next topic, which is personality disorder. This is a group of disorder characterized by personality patterns that are pervasive, inflexible, or maladaptive. Personality disorders are egocentric, lifelong, and difficult to treat. The most common used test by primary care doctors to screen for personality disorder is the Minnesota Multidisciplinary Personality Inventory. The most common used test, as we said, this is MMPI. And on the lower part of the slide number 42, we see different type of this personality disorder and definition and diagnostic criteria. Let's start with paranoid personality disorder. We have suspicious, mistrustful, secretive, isolated, and questioning of the loyalty of family and friends. And then we have schizoid disorder, in which we have choices of solitary activities, lack of close friends, emotional coldness, and no desire for employment, emotional coldness, no desire for enjoyment of close relationships. Let's go to the next slide. Schizotypal disorder. We have idea of reference, magic thinking, odd thinking, eccentric behavior, increased social anxiety, and brief psychotic episodes. The next one is histrionic disorder. In this disorder, we have the patient must be a center of attention, inappropriate sexual behavior, self-dramatization, and use physical appearance to draw attention on self. For the antisocial disorder, we have failure to conform to the social rules, lack of remorse, impulsive and aggressive towards others, irresponsible, and must be age of over 18 years old. We have a borderline personality disorder in which the patient is with unstable relationship, impulsive, recurrent social behavior, chronic feeling of emptiness, inappropriate anger, and inappropriate anger, dissociative symptoms when severely stressed, and brief psychotic episodes. For the narcissistic personality disorder, we have grandiose self of self, believe they are special, lack empathy, sense of entitlement, and require excessive admiration. For the avoidant personality disorder, we have unwillingness to get involved with people, viewing herself view self as socially inept, reluctant to take risks, and feeling of inadequacy. If we have a dependent personality disorder, we have patients which have difficulty making day-by-day decisions, unable to assume responsibility, unable to express disagreement, fear of being alone, seeks relationships as source of care. And the final is obsessive compulsive personality disorder, or OCPD. Patients that are preoccupied with details, orderly, perfectionist, excessively devoted to work, no obsession or compulsion seen, in contrast to obsessive compulsive disorder. And this is the end of the table. So let's talk about the treatment. The treatment is individual psychotherapy, number one. Number two, medications in mood or anxiety symptoms when they are present. Let's go to the next. Let's discuss anorexia nervosa. By definition, anorexia nervosa is characterized by failure to maintain the normal body weight, fear of and preoccupation of gaining weight, and body image disturbances. There is an unrealistic self-evolution as overweight. These patients tend to deny their emancipated condition. They show great concern with appearance and frequently examine and weigh themselves. They typically lose weight by maintaining strict caloric control, excessive exercise, purging, and fasting, and with laxative and diuretic abuse. Amenorrhea is often present but not required for the diagnosis. Patients are 95% female, and have 5 to 18 mortality rate. Wow. Diagnosis of anorexia is seen more frequently in teenager girls between age of 14 and 18. There is even evidence of severe weight loss, hypotension, bradycardia, lanuguhe, and edema may be present. EKG changes such as rhythm disorder occur as a result of potassium differences. Arrhythmia is the most common cause of death. Patients with maternal history of amenorrhea are 50% more likely to develop anorexia. The treatment is number one, hospitalization to prevent the dehydration, starvation, electrolyte imbalance, and death. Number two, psychotherapy. Number three, behavior therapy. And number four, SSRI, which is used to promote the weight gain. Let's go to the next slide. Bulimia nervosa. In this case, patient is characterized by frequent binge eating, as evidenced by eating a large amount of foods in a discrete amount of time, as well as a lack of control of overeating episodes. This is accompanied by compensatory behavior to prevent weight gain in a form of purging, misuse of laxative and diuretics, fasting, and excessive exercise. The patient self-evaluation is unduly influenced by body shape and weight. Bulimia is diagnosis. The bulimia is seen more frequently in women and occur later in adolescent than anorexia nervosa. Most of these women are with normal weight, but do they have history of obesity? Treatment, number one, does not require hospitalization unless severe electrolyte abnormality is present. Number two, psychotherapy. Number three, SSRI. And let's go and talk about binge eating disorder. There is a essential failure of binge eating disorder. Essential feature of binge eating disorder is recurrent episodes of binge eating that occur at least 3 times a week for 3 months. Patients are usually overweight and they usually lack a sense of control over their eating habits. The binge eating episodes are associated with eating faster than usual, eating until feeling uncomfortably full, eating large amounts of food in the absence of hunger, eating alone, and feeling disgust with oneself after the eating episode. The treatment is topiramate has proven efficiency for binge eating disorder. SSRI may have a limited benefit. So this is on the next slide, 47. Psychotherapy is indicated, which includes cognitive behavior therapy, interpersonal psychotherapy, and dialectic behavior therapy. Other specified feeding or eating disorder. This designation is used for patients which don't meet criteria of either anorexia nervosa or bulimia nervosa. Examples include: number 1, criteria for anorexia present in girls but menstruation is normal. Number 2, anorexic patient with normal weight. Number 3, use of compensatory behavior after eating normal amount of foods. And then we have sleep disorder, which is sleeping disorder. The first one is narcolepsy, which characteristically you have nightmares during the REM sleep. Then number 2, you have sleep terrors, somnambulism or sleepwalking in stage 3 and 4. It is characterized by excessive daytime sleepiness and abnormalities of the REM sleep. Narcolepsy most frequently begins in young adults. Sleep studies are usually indicated in the diagnosis. No therapy has been found to be curative, and the patient is managed with forced naps during the day. Wow. Modafinil is the medication used to maintain alertness. Modafinil. Therapy can be also includes methylphenidate or dextroamphetamine. GHB or gamma hydroxybutyrate may be given at bedtime to induce symptoms of narcolepsy and contain them at night. You have a psychiatric and physical symptoms of narcolepsy or sleep disorder. Let's go to the next slide. Here we have on the left side of this table specific feature of the narcolepsy, and then on the right specific characteristic of the sleep disorder. Narcolepsy, you have sleep attacks and cataplexy. You have hypogonic and hypopompic hallucination. and sleep paralysis. For the first one, sleep attacks, you have episodes of irreversible sleepiness and feeling refreshed upon awakening. For cataplexy, you have sudden loss of muscle tone, considered pathognomonic, and may be precipitating by loud noise or emotions. Then you have hypogonic and hypopompic hallucination, which you have hallucination that occur as the patient is going to sleep and wake up. And the last one is sleep paralysis, where the patient wakes but unable to move. This typically occurs upon awakening. We have to remember here that loss of hypocreatine results in inability to regulate sleep. And we have the last one, sleep apnea. Sleep apnea is disorder characterized by the cessation of airflow at the nose and mouth during sleep due to obstruction of the upper airway. This results in episodes of decreased arterial oxygen saturation and episodic arousal. Patients typically are overweight, they have a very loud snore, and complain of daytime fatigue. Polysomnogram will show episodes of apnea lasting more than 10 seconds, accompanied by decreased arterial oxygenation, bradycardia, and increased diaphragmatic efforts. Medical complications include arrhythmias, pulmonary hypertension, and occasionally death. The treatment is characterized by number 1, nasal continuous positive airway pressure or CPAP. Number 2, weight loss. And number 3, corrective surgery. Let's go to the next one. Human sexuality. This is a big topic. Let's start from the table, which shows definition of sexual characteristics and terminology of human sexuality. Number 1, this is sexual identity, which is based on the person's secondary sexual characteristics. Gender identity, which is based on the person's sense of maleness or femaleness established by age of 3. Gender role, this is based on external patterns of behavior that reflect inner sense of gender identity. And sexual orientation, this is based on the person's choice of love objects, may be heterosexual, homosexual, bisexual, or sexual. Masturbation, this is, let's go to the next slide, I'm sorry. Masturbation, this is a normal precursor of object-related sexual behavior. It's commonly seen in adolescents, adults, and elderly. It's problematic only if it is if it is interference with daily functioning. And the last one is homosexuality. This is not considered for mental disorder. It's removed of DSM in 1973. It may be considered normal experimentation in teenagers. Let's talk about sexual dysfunction. On this table, we see disorder, then the definition and the treatment. And there is several types of sexual dysfunction. Number 1 impotence, which is persistent or recurrent inability to obtain or maintain erection until completion of the sexual act. Number 2, rule out medical cause or medications, psychotherapy, couples sexual therapy. Number 2 is premature ejaculation. Ejaculation is before penetration or just after the penetration. Usually is due to anxiety. And the treatment is psychotherapy, behavior modification, and techniques. Stop and go or squeeze. And the treatment is with SSRI medications. Then we have the third one, which is genital pelvic pain disorder. Let's go to the next slide. Or another name is dyspareunia. This is a pain associated with sexual intercourse, not diagnosed if due to medical condition. And treatment is psychotherapy. And on slide 51, we have the last one is penetration disorder, formerly vaginismus. This is involuntary constriction of the outer third of the vagina, which is preventing from penile insertion. And the last one is this, the treatment is with psychotherapy and dilator therapy. We have to know that 50% of the smokers present with impotence. Let's talk about paraphilic disorder, or formerly paraphilias. We have to remember that pedophilia is the most common paraphilia. Paraphilia is a group of disorders that are recurrent, sexually arousing, and seen more frequently in men. They usually focus on humiliation, non-consenting partners, or use of non-living objects. Must occur for more than 6 months and cause distress, as well as adversely affect level of functioning. Do not diagnose if it is done for experimentation. So on the end of on the bottom of the slide 51, we have different types of paraphilias, as well as the type of paraphilia on the left, as well as the definition on the right. Number 1, this is exhibitionism. This is recurrent urges to expose oneself to strangers. Number 2 is fetishism, which is this is recurrent use of non-living objects to achieve sexual pleasure. Number 3 is pedophilia, which is recurrent recurrent urges or arousal towards prepubescent children. Masochism, this is recurrent use or behavior involving the act of humiliation. Let's go to the next slide. Sadism, this is recurrent use of behavior involving act of in which physical or psychological suffering of the victim is exciting. Transvestic fetishism, this is recurrent urges or behavior involving cross-dressing for sexual gratification, usually found in heterosexual males. Flirtatiorism, this is rubbing usually one's penis or erected penis against a non-consensual person for sexual gratification. And the treatment is here: number one, individual psychotherapy; number two, behavioral modification techniques such as aversive conditioning; and number three, anti-androgens or SSRI to reduce the sexual drive. Gender dysphoria, or formerly gender identity disorder. This is a disorder characterized by persistent discomfort and sense of inappropriate regarding the patient assigned sex. Diagnosis is when you have a gender identity disorder will manifest by wearing of the opposed gender's clothes, usually toys assigned to the opposite sex, play with opposite sex children when young, and feeling unhappy about the person's own sexual assignment. Patients will take hormones when older to deepen the voice if female, or soften more voice if male. Women may bind the patient will take when young and feeling unhappy about the person's own sexual assignment. Patients will take hormones when older to deepen voice, or female, or if female, or soften voice if male. Women may bind their breasts, and men may hide their penises and testicles. It seems more frequently in young men. Treatment is sexual reassignment surgery if approved. Number two is individual psychotherapy. And let's go to the last slide. Voila! Suicide. Suicide, especially violent suicide, is associated with decreased level of serotonin. Native Americans are ethnic group with the high suicide rate. Patients with psychiatric history are 34 times greater risk to commit suicide. Protective factor includes connection to the family, pregnancy, responsibility for children, and religious affiliations. Firearms is the most common method used for both men and women to commit suicide. Therefore, be sure to ask about access to guns. Pills and poison is the most common method for women to attempt suicide. Presentation usually has a recent suicide attempt. Number two, complaints of suicidal thoughts. Number three, admission to suicidal so we have a presentation usually is a recent suicidal attempt. Number two, complaints of suicidal thoughts. Number three, admission of suicidal thoughts. And number four, demonstration of suicidal behavior, such as buying weapons, giving away possessions, and writing a will. Risk factors. Number one, men. Number two, old adults. Number three, social isolation. Number four, presence of psychiatric illness and drug abuse. Number four, preserved hopelessness. And number five, previous attempts, which is number one, a risk factor. And the treatment, you have to hospitalize the patient, and you need to take all the threats seriously. And dear listeners, this is the end of the lecture for psychiatry. Again, this is Professor Triple N or Nick, PA from Brooklyn, New York. If you need to reach me, you can email me to NICK, M like Mary, D like dog, the number 1 @gmail.com. Thank you.